You can start now.
Can we start?
Yes, sir. Do I start, sir?
Yes, sir, you can start.
Are we live?
Yes, sir. I already informed.
Okay, right. So I welcome you all to the second session of this IAP PJ case presentation that is conducted by IAP Pune every fortnightly. And this time we have Dr. Bhavna, who is a junior resident 3 in Department of Pediatrics at DY Patil Medical College. Dr. Sampada Tambolkar and Dr. Shiji and Dr. Agarkar sir are our mentors. And this time we have Dr. Vikram Kumar, who is a professor of pediatrics at Subhaya Institute of Medical Sciences. He will be one of our faculty. And we have our own pediatric neurologist, Dr. Kulkarni, who will be the second faculty. So I think without any further delay, let us get started with the case.
Hello.
You can start, Dr. Bhavna, you can start the case presentation.
Good afternoon to one and all present here. I'm Dr. Bhavna, third year pediatric resident from Dr. D.Y. Patil Medical College. And I'll be presenting today's IAP case presentation and prepare my case presentation under the guidance of my Professor Dr. Sampada Tambolkar, my Associate Professor in Pediatric Neurology, Dr. Shiji Chalikar, and my HOD, Dr. Sharad Agarkar, sir. My patient is a 5-month-old female child by third order by birth, born to a non-consanguineous marriage, belonging to a lower middle class family according to modified Kuppuswamy classification, hailing from Pune. The informant is a mother whose reliability is good. She came with chief complaints of repeated episodes of seizures since day 3 of life and non-attainment of milestones since birth. Since her complaints have started since day 3 of life and she has a significant antenatal history, I would like to begin with her antenatal history. The age of the mother at conception is 24 years. It was a spontaneous conception and no infertility treatment was given. Her pregnancy was registered.
Just a second, Dr.
The mother was diagnosed with hypothyroidism at 4 months of gestation, for which oral medication.
Dr. Bhavna, can you hear me?
Yes, sir.
Yeah. Can I come in between, or do you have any symptoms that we have to discuss at the end of
No, you can interrupt, no problem.
Yeah, please go back
You
to
can
the
ask.
first slide.
Pardon, sir?
Could you go back to your second presentation slide, please?
Yes, sir. So this slide, sir?
Yes. Yeah. I can put up the slide. Okay, so it's a 5-month-old baby girl has come with these chief complaints. So, what would you suggest? What are things come to your mind? Hello. Hello.
We can hear you.
Yeah, there. Dr. Bhavna there.
Dr. Bhavna, please unmute.
What was the question? Could you repeat, Dr. Vikram?
So it's a 5-month-old baby girl has come with these chief complaints. Could you just interpret these chief complaints? What all strikes your mind? 3-4 things.
A 5-month-old. I'm sorry, sir. I'm not able to hear you clearly, sir.
The question is, if it is a 5-month-old child who comes with these chief complaints, what are the things that come to your mind?
Okay. Sir, the patient has come with complaints of seizures within day 3 of life. So I would like to look at the differential diagnosis which can cause neonatal seizures on day 3 of life. So one common example is in perinatal asphyxia, otherwise hypoglycemia, metabolic disturbances such as hypoglycemia or hypocalcemia, and also there could be some other metabolic disturbances that can cause seizures on the day 3 of life.
Okay, so
In some cases.
great, excellent. So you would like to put under broad headings here now? Broad headings that can.
Pardon?
You like to put these things into 2-3 broad headings. I'm asking you these things because you're a third-year resident. So,
Yes, sir.
so if you would like to put these under 2 or 3 broad headings, what would those 3 broad headings be?
I would like to divide it into either an infective cause. For example, infective causes,
That's
it can
okay.
either be
Infective. Yeah, what
meningitis.
else?
Apart from infective, any structural brain disorders, any cerebral dysgenesis, and I would like to divide it into hemorrhagic disorders such as intraventricular hemorrhage or
Okay, vascular. I
subarachnoid
want to put
hemorrhage,
as vascular.
vascular,
So you would
and
think of infective,
the third would
structural,
be
and vascular.
in vascular causes,
Okay,
and even metabolic, sir, metabolic causes as well.
fine.
And I would also like to include perinatal asphyxia also, sir.
Okay.
Within, so I would include that also, sir.
Okay. Yeah.
And
You could go ahead.
yes, sir.
So, hello, hello, Dr. Vana.
Yes, sir.
So you can
Yes, sir.
categorize,
Yes, sir.
you can just remember the mnemonic A, B, C, D, E. A for asphyxia, B for bleed, C for cerebral degenesis, D for drugs, E for encephalitis. So you can definitely,
Yes, sir.
whenever the child comes as neonatal CS,
Yes, sir.
you can, as
Yes, sir.
Vikram sir told in a very categoric manner, you have to make some groups and then you have to
Yes,
think
sir.
about it. Go ahead.
Yes, sir. Yes, sir. Her antenatal history, the mother's age at conception was 24 years. It was a spontaneous conception and no infertility treatment was taken. Her pregnancy was a registered pregnancy. The mother was diagnosed with hypothyroidism at 4 months of gestation, for which oral medication was taken, which was continued till delivery. Her antenatal ultrasound revealed enlargement of the left kidney, for which the parents were asked to follow up after the birth of the child. She had a weight gain of 8 kgs during her pregnancy, which was adequate. There was no history of altered amniotic fluid quantity, altered fetal movements, or exposure to alcohol, tobacco, or radiation.
Please share your slides. We can't see your slides.
So my slides are not visible. Oh, 1 second, sir. Is it visible, sir?
Yeah.
Yes, sir. Sir, shall I move on, sir?
Yeah,
From
yeah,
antenatal.
Go ahead.
birth history. She had a full-term elective LSCS in view of breech presentation. The baby cried immediately after birth, had a birth weight of 3 kgs, and was shifted to the mother's side. Breastfeeding was initiated within 4 hours after delivery. The baby passed stools within 24 hours of life, and the baby passed urine within 48 hours of life.
Okay.
History, yes, sir.
Yeah. So, looking at the antenatal and birth details,
Yes,
what
sir.
are things? What are things can you just almost certainly rule out?
So looking at her antenatal and birth history, I would rule out perinatal asphyxia, sir, since there was no need for any resuscitation in the baby, and since there's no history of any altered fetal movements or any altered. I would like to rule out any causes of myotonic dystrophy or any muscle disorders, congenital muscle disorders.
Okay. I mean,
And
what congenital muscle disorders would present with seizures? I'm talking in relevance to the chief complaints here and the
yes, sir.
broad headings that we discussed. So I don't think congenital myotonic or muscle disorders were anywhere near to our thinking, right?
Pardon, sir?
I think you need to talk with relevance to the chief complaints.
Yes, sir. Yes, sir.
Yeah. So we never thought of congenital myotonic dystrophy or congenital muscle diseases.
Yes, sir. Yes, sir. Yes, sir.
So that we need not have to discuss at all. Yeah. I'm just want you to interpret these antenatal and birth details. Almost
So
certainly,
from
what are
her,
things can you rule in and rule out?
so I would certainly rule out perinatal asphyxia, sir. Since she had a normal birth history and there was no need for any resuscitation, sir, post delivery.
Okay.
And also based on her antenatal for causes of seizures, I would also any history of anesthetic drugs which can cause seizures. I would rule out because there's no significant history to suggest that the mother was administered anesthetic drugs to cause seizures immediately after delivery.
Okay. It was a term cesarean section, is it?
Yes, sir. It was a term cesarean section.
Right.
With
So
the
one
breathing
major thing
section.
that you would like to rule out is probable asphyxia.
Yes, sir. Yes, sir.
Okay. What else?
So also, and her antenatal scans have not suggestive of any anomalies as such, any brain anomalies as such. It would also rule out any cerebral disorders which can cause microcephaly, which can lead to development of
We
seizures.
don't go too far because most of the time when they do an anomaly scan, I would like to call it as an anomaly scan or a morphogenesis scan. Unless you
Yes, sir.
ask for it, they won't really give you because you already have one anomaly there. Whatever that means, enlargement of left kidney, whatever that means.
Yes,
Whether
sir.
kidneys
Yes,
are
sir.
enlarged, whether the collecting system is involved, we don't know. Just mentions
Yes,
that there
sir.
is enlargement of left kidney. So, would you like to elaborate on that?
So enlargement of the left kidney was what the parents were informed. There could be many reasons. Probably the child had antenatal hydronephrosis, which needs to be further evaluated following birth, based on the AP diameter and to evaluate
Okay. So, enlargement of kidney indicates that there is some abnormality in the genitourinary system. We don't
in
know.
the genetic. Yes, sir.
Okay. So, have you heard of Acute?
Yes, sir.
What does
That could
that
be
stand for?
congenital anomalies of the kidney and urinary tract, sir.
Okay. If we were to take this as a part of Acute,
Yes, sir.
what things can you need to keep in mind?
Pardon, sir?
If you think that this is a part of Acute,
Yes, sir.
um, what does the child probably have? I mean, in order for it to start throwing seizures on.
So there are many genetic Acute disorders which needs
Yeah,
to be
to simplify it, you just can't rule out intracranial structural abnormalities at this stage.
Yes, sir. Yes, sir.
And then probably you might have to start thinking of any genetic or probably a chromosomal problem. Genetic, we don't know, because you said it's a non-consanguineous marriage.
Non-consanguineous marriage, yes,
so
sir.
genetic probably could still be there, but unlikely. Or
Yes, sir.
a chromosomal something that will.
Yes, sir.
Yeah. Okay. Then looking at the birth history, the details of birth, what are things? Again, you can almost rule out or rule in. You say it was a term.
It was a term female child, sir. Cried immediately after birth. She was immediately shifted to the mother's side. She was feeding well within 4 hours after delivery. She passed stools and urine also, sir, within 48 hours, sir.
This is the first baby? Primary gravida mother?
No, sir. No, sir. No, sir. No, sir. This is her third baby, sir.
Right.
Okay. So, full term baby born out of an elective C-section for
Yes,
which presentation?
Yes, sir.
Okay. So
since it's term, that would also rule out the possibility of IVH as well, sir.
pardon me, I didn't hear you.
Since it's a term baby, that would also rule out the possibility of intraventricular hemorrhage, sir.
Not really. You could just rule out probably unlikely to be an IUGR is what you can rule out. Intraventricular hemorrhage you can't rule out just by, because it is not an it's a consequence of something, right? Intraventricular hemorrhage.
Yes, sir.
It's a consequence of something. So you can't directly say that intraventricular hemorrhage can be ruled out. At this point, because it's a full-term delivery, you just say probably an IUGR status or probably an intrauterine infection can be almost ruled out, or very unlikely.
Yes, sir.
Okay. Yeah, right. Go ahead.
Or history of presenting illness. The baby was apparently normal till day 3 of life, following which she developed one episode of tonic-clonic movements involving the bilateral upper and lower limbs, which lasted for 1 to 2 minutes and then subsided spontaneously. The mother perceived these movements to be insignificant and did not seek any intervention. The baby had similar episodes on day 8 and 18 of life, both of which were self-limiting. On further questioning, the mother also mentioned that the baby had decreased activity for a few minutes immediately following the episodes. The baby was alert, active, and feeding well in between these episodes. From the 3rd week of life onwards, the mother noticed that the baby had feeding difficulties and was unable to latch on to the breast effectively. From the 4th week of life, she noticed progressive loss of weight in the baby, along with a generalized decreased activity in the baby. At 6 weeks of age, the baby had a recurrence of seizures, this time with multiple episodes, which initially started as tonic-clonic movements of the left lower limb, which then progressed to involve all 4 limbs and was associated with uprolling of eyeballs. Each episode lasted for 1 to 2 minutes, after which it subsided spontaneously. The frequency of the seizure episodes increased to 1 seizure every 20 minutes, which was followed by post-ictal drowsiness after the episode. There was, however, regaining of consciousness in between the episodes. Along with this, the mother also noticed multiple episodes of jerky movements of bilateral upper limbs, which was possibly suggestive of myoclonus. The baby was immediately taken to a nearby private hospital where the parents were informed of significant weight loss in the baby, and the baby weighed 1.5 kgs at the time of presentation, because of which the baby was admitted in the NICU. She was immediately administered IV medications which aborted her seizures. She was taken on room air and started on IV fluids. There's history of 1 blood transfusion during her stay in the NICU. And for frequency of seizure episodes decreased from about 12 to 13 per day to 6 to 8 episodes per day during her course in the NICU. On day 2 of admission, the baby was started on express breast milk via orogastric tube, which was converted to Vati spoon feeds, which was administered by the mother after 2 days. There was a history of 500 grams of weight gain during her course in the NICU. Her urine and stool output were maintained throughout her stay in the NICU. 8 days
So,
after
yeah, Bhavna,
admission.
excuse me. Can I interrupt
Yes,
you?
sir.
Yeah. Now,
Yes, sir. Yes, sir.
till this time, by now baby's already become say 5 months. The seizure started at around 3 days of life.
6 weeks, sir.
Correct?
Yes, sir.
Yeah, and now the child,
Yes,
that
sir.
baby is having multifocal seizures. Correct? So now,
Yes,
as
sir.
Dr. Vikram initially asked, what
Yes,
kind
sir.
of sets you want to rule out in this child? Now, after seeing the semiologists say it is very difficult in neonatal period. But however, the child is having jerks, the child is having multifocal seizures. So there are multiple
Yes, sir.
seizure types, correct, including jerks.
Yes, sir.
So now
Yes,
here,
sir.
which all say differentials would you like to consider at this point of time?
So at this point of time, since her seizures have progressed, it's one is the early onset, sir. It started on day 3 of life, and the fact that it has progressed beyond 6 weeks of life, I would like to consider one is the possibility of a metabolic disorder, sir.
Okay,
Mainly because of the
in say metabolic, which metabolic disorders would you like to consider?
so metabolic disorders including urea cycle disorders or organic acidemias and non-ketotic hyperglycemias.
Correct. So
All of
here,
which
if you can
yes, sir.
see when the child presents early, say on day 3, day 4, so low molecular weight
Yes,
disorders, say metabolic disorders, they are early to come than the large
Yes,
molecular
sir.
weight disorders.
Large molecule, yes, sir.
Correct. Then
And usually the seizures will be difficult to manage also in the case of metabolic disorders. Uh, I would also like to consider the possibility of genetic disorders, sir. Genetic disorders also, or any cerebral malformations, they will also present their, especially if they can present in the 3 days of life, and then progressively at 6 weeks of life, they're still present, and they are also difficult to control, sir.
correct. Now how to remember for for the PGs. So either this is EIE, that is the early infantile epileptic encephalopathies, or early myoclonic epilepsies. Okay, now the nomenclature is a little bit changed. Correct. So remember
Yes, sir.
M for M. When you are getting myoclonic, different multiple seizure types, think about EMEs, that is early myoclonic epilepsies. The cause could be metabolic one. And the
Yes, sir.
EIEs, that is the early infantile epileptic
Early
encephalopathies.
infantile.
Think about the structural
Yes.
malformations, cerebral malformations, Otahara-like syndromes. Okay.
Yes, sir.
So EIE and EME, you should consider metabolic, and there is much overlap, metabolic and genetic and structural, as per the recent IAP classification. Okay.
Yes, sir. Yes, sir.
Yeah.
So
anything would you like to add, Vikram sir?
yeah, I mean, nice discussion. So here, I just would like to know your understanding of how you classify and how you describe a seizure. You said the child had seizure at the age of 3 days. First seizure.
Yes, sir.
Said it
Pardon?
had, yeah, when you presented it as a seizure on day 3 of life.
Yes, sir.
Could you go back to that slide? You describe it as tonic and clonic. Yeah. So one episode tonic clonic, bilateral upper and lower limbs. If you had this seizure type, how would you name the seizure as based on the latest ILA classification? Because you know what? Do you understand by this terminology called
Yes, sir.
acute symptomatic seizure?
Yes, sir. Yes, sir.
Yeah. So this child initially on day 3, what do you think? I mean, looking at how the thing has progressed, is it a part of acute symptomatic seizure or epilepsy?
So, based on how it has the progressed, I would like to think of it as a not an acute symptomatic epilepsy, sir.
No, no. See,
Problem.
these
An
two are
epilepsy.
different terms. Two are different terms. One is acute symptomatic seizure. The other one is epilepsy.
Epilepsy, sir. I would like to
Correct.
consider
Yeah. Why do you call it as
epilepsy.
epilepsy?
So, because one is the multiple episodes of seizure, sir, and it occurred on day 3 of life, and then it recurred again after more than 24 hours later, again at day 6th week of life, it is recurred, sir.
Yeah. So the definition of epilepsy says the tendency to have recurrent seizures or more than 2 seizures 24 hours. So this is probably an epilepsy or an epileptic syndrome.
Yes, sir.
So what all things can give rise to an epileptic? I mean, an epileptic syndrome sort of thing at such an young age.
So, like sir mentioned, any structural brain malformations in the case of early infantile epileptic encephalopathy, or it can be hello,
I mean,
or
just
it can be
looking at the just looking at the chief complaints, can you say
Yes,
that the
sir.
child also has developed encephalopathy over the period of 2 weeks, 2 to 3 weeks?
Looking based on the history that the mother has given, I can say that she's developed encephalopathy because the mother is saying she's not been feeding properly and she has decreased activity also over the span of 6 weeks. So I would like to consider that she's developing encephalopathy.
Okay. So you said initially they were self-limiting.
Yes, sir. Yes, sir.
Okay. So I mean, what do you understand by that?
So they were self-limiting, as in each episode would subside without the need for any medication. They would subside within 1 to 2 minutes, sir. The duration was less than 5 minutes, sir. But however, there was a tendency for the seizures to recur, sir. They would subside, and there was no the child remained normal in between the episodes. But the seizures would recur every 20 minutes, sir.
See, I mean, looking at the semiology or looking at the progression of the syndrome, you said initially there used to be 1 seizure a day, and the semiology of seizure, was it focal or generalized? Of course, in the
So
neonatal period, you can't really say that.
yes, sir.
In neonatal period, you can't really classify it accordingly. But you said initially, for the first few days, it used to be 1 or 2 seizures a day, and
Yes,
slowly
sir.
the number of seizures and frequency of seizures both increased.
Yes, sir.
Yeah. So, and each time we don't know the duration of each episode of seizure. And you say the interictal period, the child was apparently all right.
Yeah, apparently the child was all
Yeah.
right, sir, in
So-
between the episodes.
Excellent. So, how do you interpret this progression?
So I would like to consider the possibility of some progressive encephalopathy, since initially she had only 1 seizure episodes per day. Later it progressed to multiple seizure episodes per day. And also the fact that she was regaining consciousness in between, sir. So initially, I would like to think of some encephalopathic disorder, sir, which is progressive in nature.
Okay, so by the end of almost 3 weeks, it had become so severe that
The child
Sorry, sir.
okay, so by the end of 3 weeks, the
encephalopathy.
problem had become
Between
so
the-
severe. Speak.
Yes, sir.
I'll just mute myself. I think someone else wants to. Okay, so by the end of 3 weeks, it had progressed to an extent that the child already had feeding difficulties because of ineffective latching. Is it
Yes,
what
sir.
you mean?
Yes, sir. Yes, sir.
Okay, so
The seizures at the third and fourth week is when the mother started noticing that the baby had difficulty feedings and the baby had progressive weight loss. At that time, she didn't notice any increase in the frequency of seizures. Gradually, from the 6th week of life onwards, she's noticed that the seizure frequency also increased, sir, and it was associated with other features like uprolling of eyeballs and post-ictal drowsiness as well, sir.
okay, so because in your in the presentation slide you have mentioned that by third week of life it was probably
She had
already
feeding difficulties, sir. Yes, sir.
yeah, and ineffective latching. So I couldn't really interpret why ineffective latching set in there. And do you think the baby started losing weight because of inability to feed?
So there could be an underlying reason for probably leading to failure and thrive in the child. There could be an organic cause behind why the child had developed feeding difficulties and developed progressive loss of weight. The fact that the parents ignored the seizures on the day 3, 8, and 18 of life, and they haven't done anything, that could be a probable organic reason for the epilepsy to occur, which is not only involves the brain but also involves the other systems, which is and also involve the development of the baby, that is the ability of the baby to feed and gain weight, which is probably why the baby was losing weight and unable to feed, sir.
I mean,
You said about feeding difficulties. So can you
Yes,
describe what exactly was the feeding difficulty? Was it that child was not able to suck? Was it that child was not able to swallow? Or child was sucking but there was a drooling? Or there was a stridor? Or there was some kind of a, something suggestive of aspiration? Is it possible?
No,
Tell
ma'am.
these.
The mother noticed that the baby would not latch onto her breast properly. That the baby was quite weak. She had decreased activity, and the baby would swallow when she would feed. But when she would attempt to directly breastfeed the baby would not latch on and suck properly. But
So she
the
must
baby
have tried Vati spoon feeding, right?
She didn't try Vati spoon feeding, ma'am. When she was admitted at the hospital at 6 weeks, that's when they advised her to try Vati spoon feeding, and that's when she started Vati spoon feeding. And she said once she started Vati spoon feeding, the baby was started accepting feeds better.
Yeah, I mean, what I just wanted to know was if the child, I mean, was there a condition wherein the child used to have both convulsive and aconvulsive state, because of which when the child was convulsing, it was like seizure, and when the child was aconvulsive, the child was not active enough to latch on and feed. And over a period of time, from convulsive, aconvulsive status, did the child become completely convulsive?
So
did you get the point? Because there are states where the seizure can be aconvulsive, and then it can progress to have multiple convulsive episodes. So seizures can also be aconvulsive. That is what I just wanted. Anyways, yeah. So baby has had a torrid time and has lost quite a lot of weight during this time, and then was admitted for significant failure to thrive, is what you mean to say, and then received some medications and blood transfusion.
Yes, sir.
So the condition was such that the child started really thriving badly, right?
Yes, sir.
Okay, and when it was significant, it was admitted in NICU, and seizures were reported with some medications and some blood transfusions had to be given.
Yes, sir. Yes, sir.
Right. So, and it had gone to the extent that the child couldn't feed well, so it had to be fed through an orogastric tube.
Yes, sir. That was for 2 days after admission, sir. And from the third day of admission, the mother was trained to start Vati spoon feeding the baby, sir.
Oh, right. Okay, so you can go ahead.
Yes, sir. So the baby had a history of 500 grams of weight gain during her course in the NICU. Urine and stool output were maintained throughout her course in the NICU. She was then discharged from the NICU after 8 days. When she was vitally stable, she had a decreased seizure frequency. and she was feeding on express breast milk via Vati spoon feeds. The baby was then taken home, and at about 2 months of age, the mother started noticing rapid abnormal eye movements in the baby. It was present intermittently throughout the day, and it subsided during sleep. At around 3 months of age, the mother noticed that the baby had a delay in attainment of milestones as compared to the first child. She did not have any head control. There was no vocalization or social smile. The baby did not make eye contact or recognize the mother. However, according to the mother, the baby would alert to sound. The mother also gives history of difficulty in carrying the baby, as the baby would frequently slip from her grip. By about 5 months of age, there was a decrease in the generalized activity of the child, and the mother also noticed that the baby did not alert to sound. And currently, the number of the seizure episodes are about 5 to 6 episodes per day, and the baby has decreased activity and has delayed milestones. Due to the above complaints, the baby was then referred to our hospital for admission. There was no history to suggestive of any infections such as fever or ear discharge or any
Yeah,
incessant
so
crying.
this is where you need to be more specific, because we've already discussed quite a lot of things.
Yes, sir.
Do you really want to rule out ear discharge and all in this child?
So the possibility of CNS infections, I would like to rule out, sir.
Yeah,
Any meningitis.
Do you think meningitis or any infectious disease would go on for such a long time without really causing a catastrophic problem?
No, sir, but the possibility of getting an infection again, because she had a turbulent course from 6 weeks of life.
Okay, third day.
Yes, sir.
Day
Yes,
3,
sir.
yeah.
Bhavna,
Yes, sir.
now can you explain those rapid abnormal eye movements?
Yes, sir. The mother gave history that she had an abnormal continuous movement of the eyeballs, which used to be present intermittently, sir, throughout the day. Every time the child was awake and active, the mother noticed that she had horizontal movements of her eyeballs, sir.
So whether it was in this nystagmus, what kind of movements, whether it is oxophonous, I am unable to get from the only rapid abnormal eye movements.
So,
Does she have a video of it?
pardon, sir?
Does she have a video? Did she show you a video of something?
Yes, sir. Yes, sir. Yes, sir. The mother noticed that there were
It may
abnormal eye
have been
movements.
pendular. Was it pendular?
No, ma'am. On examination, it was more of jerky nystagmus. It was not a pendular nystagmus.
Okay.
I mean,
But,
how do you define nystagmus in a sense? It's a very good question, Dr. Vishwanath. When you have a child presenting, I mean, when you have child being brought to you with abnormal eye movements, it becomes very difficult. I mean, it becomes very pertinent for you to exactly go into the details of what those rhythmic or whatever abnormal movements of the eyes are. So, what do you think? What do you make of these abnormal movements?
Dr. Vikram,
So,
can you speak in your mic? Can you please speak in your mic? I mean, just little closer whenever you speak.
Okay, so
We are getting most of your questions, but just
okay. That was a good question by Dr. Vishnu.
So, based on her history, I would like to consider the possibility of nystagmus, but I would want to confirm on my examination whether it was actually a nystagmus or whether it was some normal eye movements that the mother mentioned, sir.
So, how do you define nystagmus?
So, nystagmus is a rapid to and fro movement of the eyeball, sir. It can either be of equal amplitude or if it's usually of equal amplitude in either in the horizontal or vertical direction, sir.
Or torsional?
And pardon,
horizontal,
sir?
vertical, or torsional?
Or rotatory, sir. Or rotatory.
So they are abnormal,
And
rhythmic.
Abnormal rhythmic movement.
Yeah. So rhythmic is a very important terminology associated with nystagmus.
Abnormal,
So-
rhythmic, and involuntary.
Absolutely. So maybe if you could have asked 2-3 more questions, you could have found it out. But I can understand it's quite difficult for you at this time, just on history, to really know whether it was studied. So this child developed at around 2 months of age, abnormal eye movements.
Yes, sir.
Yeah.
Hey, have you told anything about vision of the child so far? I missed
Ma'am, there was
part
no.
of your.
At 3 months of age, the mother noticed that the child was not making eye contact with her or recognizing the mother. But she would alert hearing. She felt hearing was intact, but she noticed vision. She was doubtful of the baby's vision because she was not making any eye contact or looking at the mother, even when she gave any stimulus in front of the baby.
And she had not noticed it before that.
No, ma'am. She started noticing it at 3 months of age.
Okay.
This because she had another compared to her first child, she noticed that this baby hadn't attained any of the milestones.
Mhm. Okay.
Negative history. The baby did not have any history of cranial nerve involvement in the form of drooping eyelids, facial asymmetry while crying, nasal regurgitation. The baby did not have any history of stiffness or difficulty while changing the diapers. The baby did not have any history of involuntary movements of the limbs, and there was no history to suggest metabolic disorders in the form of recurrent vomiting, intolerance to feeds, increased irritability. There was no history of abnormal body or urine odor noticed by the mother.
Here, I would like to ask you, in a sense, I mean, with all this elaborate history and so many findings already, would you still want to take all this history to rule out things? Because where do you ever come across with these chief complaints associated with these negative complaints? Would
So
you ever
I
come across
would.
a child with a progressive neurological disorder, probably a progressive encephalopathy associated with ear discharge, involuntary movement of limb?
It is no. It is unlikely that a progressive encephalopathy would be due to acute infection, sir. But I would still like to rule out the possibility due to the episode at which they came and presented with us. We would still like to rule out. We would ask them. We would ask the mother if there was any history of fever or ear discharge to rule out if there could have been any infection at some point of time.
Yeah, I mean, you need not have to mention, I guess. I mean, no history of involuntary movements of limbs and all. It doesn't really make sense here.
Okay, sir.
And feeding intolerance, again, what exactly do you mean by that? Because the child has feeding problems.
Yeah, the baby has feeding difficulty, feeding intolerance in terms of vomiting or regurgitation of feeds,
Yeah, you
or
could just put it
abdominal
that
distension.
way. You could just put that the child doesn't have recurrent vomiting and increased irritability. I mean, these become quite subjective for you to really get answers for. I don't
Okay,
think you
sir.
need to put food intolerance, sorry, feeding intolerance and increased irritability. Otherwise, they are all the rest are okay. Yeah.
Okay, sir.
No, even
I would.
why? Just a minute, Bhavana. Go back to your previous slide. Why you mentioned about incessant crying?
So again, to rule out either the possibility of CNS infections or the possibility of a metabolic disorder, sir.
But they may not
Excessive
really give you too
irritability,
many clues.
inconsolable cry.
Say, look. Now, in case of neurology, when the child say there is say what where you are trying to fit, I'm little unable to understand. Say if you are seeing a child
Yes, sir.
who is irritable,
Yes, sir.
who is having a
Yes, sir.
progressive neurological disorder
Yes, sir.
who is showing failure to thrive, your set of differentials, they will change.
Yes,
Now
sir.
here, you are dealing
Yes,
with a
sir.
child who is having symptomatology from day 3 of life and which
Yes,
is
sir.
progressive,
Yes, sir.
associated with multi-system involvement,
Yes, sir.
correct? He had
Yes, sir.
antenatal diagnosed hydronephrosis, correct?
Yes, sir.
Now these two, there is difference. Say, so what you are trying to tell in this, whether this child is having, say, chronic progressive neurological disorder?
Yes, sir.
So if it is so, you need not have to mention CNS infections in this setup.
Yes, sir. So, but we would still ask the mother to rule out if at some point of time to rule out the possibility that the baby's had some infection at some point of time.
Okay, go ahead.
Yes, sir. There was no history to suggest the involvement of other systems, such as there was no history of suck cycle, bluish discoloration of the body, or difficulty in breathing. The baby did not have history of cough, cold, or admission for recurrent respiratory infections. There was no history of involvement of the GIT. There was no history of icterus, abdominal distension, loose stools, or constipation. And there was no history of suggestive of involvement of the renal system in the form of edema, periorbital puffiness, or decreased urine output.
Yeah, I mean, you need to be slightly careful before putting in too many negative history or too many of these complaints, because uh, at this stage we know very likely that these systems are not involved just by analyzing the chief complaints. Um,
Okay,
unless
sir.
you are really suspecting multi-systemic disorder involving various other organs, you need to be slightly careful. Yeah.
Yes, sir.
So
Based on the antenatal finding of enlarged kidney, we wanted to rule out if there was some renal problem in the child following birth, sir.
yeah, even if there was a significant renal problem, it couldn't present with edema or anasarca and this kind of encephalopathy.
Yes, sir.
Or decreased urine output. I don't know, whatever that means. So I think you need to be slightly more structured in the sense to really fit into a lot of negative complaints. I don't know, because just by looking into the chief complaints and analyzing the chief complaints with your present history, we have sort of come to a lot. I mean, we have narrowed down to a very large extent just by understanding the symptomatology. So I think.
Can this be some congenital infection? Congenital infection or some kind of a, like let's say CMV infection. It can have visual problems, it can have seizures,
Yes,
it can
ma'am.
have failure to thrive. I
Yes,
mean,
ma'am. The
CMV
possibility of
also,
congenital infections is there, except for the antenatal history did not give any history of any primary infection in the
retrovirus
mouth.
or
Yes, ma'am. Yes, ma'am.
retrovirus or maybe some kind of a immunodeficiency with kind of a CNS infections or something like that. Is it? Are we so confident so far that these things will not be there? This is a question to experts in the panel.
Yeah, I mean, if I were to analyze it, a congenital or an intrauterine infection, by that I mean not congenital infection, because for you to really define congenital infection is difficult. You probably intrauterine infection manifesting this way, with seizures at day 3 of life, with the predominantly neurological progression in the form of increasing frequency of seizures and frequency of seizures, probably associated with the progressive encephalopathy, uh, which has led to failure to thrive in the child. There are not too many intrauterine infections that represent like this.
Okay.
I will be wrong, but I wouldn't really think of an intrauterine infection presenting this way.
Sure.
Because if the history what Bhavna has presented, and if the progression has been the same as she has given us, there are not. It's a progressive disease. It's a progressive CNS disease that is manifested quite early. And most of the intrauterine infections, even if they infect the brain, they wouldn't be progressive to this extent. I think Dr. Vishwanath would add if they're wrong.
Dr. Vishwanath, do you agree that this could be congenital
Yes,
infection?
I'm totally agree. At this point of time, say day 3, the dysmorphism, and it would like more static course like this aggressive course. This baby is having very aggressive course from day 3 onwards, progressive course. So I would like to keep, okay, we can think about serious infections, but the differential would be much lower.
The birth weight was also, I think, 3 kilos.
3 kgs.
Yeah, which goes
Yes, sir.
against.
You can go ahead.
Developmental history, gross motor, the child is baby is currently 5 months old. Baby has not attained neck holding. Fine motor, the baby opens her hands simultaneously. However, there is no grasp. There is no voluntary grasp. Language, the baby would alert to sound at 2 months of age. Currently, the baby does not respond to any vocal stimuli. There is no vocalization or cooing. Social milestones, there is no face regard and there is no social smile. The baby does not recognize her mother. Hearing, there is no response to sound stimulus, and development of vision, there is no fixation or following of any visual stimulus, and there is no face regard towards the mother. Based on developmental.
Bhavna, there is
Yes, sir.
alert to sound present at 2 months
Yes,
and
sir.
no response to sound stimuli.
Currently, the baby does not respond to vocal stimuli.
So it means that baby is having progressively deterioration again as far as hearing is concerned.
Only as per her language, only as per her the history given by the mother, only there is a deterioration in her language or hearing, sir. The other milestones were not attained at all, sir. But according to the mother, she could hear or she would alert to sound at 2 months, and currently she does not respond to any vocal stimulus.
So baby used to be get alerted at 2 months, correct, to the sound.
Yes, sir. Yes, sir.
And now baby is not responding to any stimuli.
No, sir.
Okay.
Okay.
At this point, I just would like to know. I mean, because it's quite difficult for you to really assess the development here, for you to really put it as global developmental delay. Because for you, you should have a proper understanding of how exactly development proceeds. We were discussing about the language and speech. Can you differentiate what language is and speech is? What is language? Have you understood what language is and what speech is?
Pardon, sir?
Could you just elaborate what you've understood about what language is and what speech is?
So speech refers to the word output, sir. That is the noises or the ability to the word output of the child, or the ability to make a sound, sir.
Yeah,
Language is the ability to communicate.
Not
Yes,
waste too
sir.
much of time. I'll just try to simplify it. See, language, you have 5 headings. Can you tell me the 5 headings under which you assess language? 5 points or 5 domains under language. See, language is, what you have to understand is converting thoughts into comprehensible method of communication. As simple as that.
Yes, sir. Yes, sir.
See, language is, you are converting thoughts into comprehensible method of communication. So you assess language under speaking, writing, repeating, reading, and listening and hearing. So these 5 things. Language.
Yes, sir.
Whereas
Yes,
speech
sir.
is, what you have to understand about speech is language is already there in speech. So converting language into audible sounds is speech. So language has 5 components.
Yes, sir.
So here, what do you think is the problem? Language or speech? What comes first, language or speech?
So first is language, sir. Then speech.
So if you say the child's thing is less than 2 months of age, the overall development, how could you say that there is delay?
So
Is it
because
developmental delay, developmental arrest, or developmental regression? What is it?
so there is a developmental delay, sir. There's no, because when it comes to language milestones, there is a developmental regression. But however, if we take all the other milestones together, then there is a developmental delay, sir, because none of the other milestones have been attained as yet. So it's not that it has been arrested.
Mm-hmm. Okay, so
But
you think the baby is attaining? Okay, so someone is asking, could you repeat 5 domains of language? Please write it down. See, if you understand this, it's very easy. See, language, you have to understand that for you to assess language, there are you will assess under 5 domains. So what are those? Speech or
sir,
speaking,
speech, yes, sir.
speaking,
Reading,
reading,
writing.
very good, writing,
Reading,
repeating, very important,
writing,
repeating, and then listening. So you can hear, I mean, you can remember it this way. You hear, that is listening and
But,
hearing. Then,
yes, sir.
then you need to repeat, repeating,
Repeating,
then reading, writing, and speaking. So all these 5 things under language.
yes, sir.
Okay. Yeah, someone asked in the question and answer, so I'm just repeating. So my language milestones are good.
Yes, sir.
You agree? Okay. Go ahead. So at this point in time, we can just say that the child has global developmental issue. All the domains are affected.
Of all, yes, sir. All her domains are affected. And her developmental age is less than 2 months, sir. It's affected all her gross, fine motor, language, and social milestones, sir.
Okay.
Moving on to her family history, she was born to a non-consanguineous marriage. Their first child was a male child who's 5 years old currently. He was born by a normal vaginal delivery, and there's no significant complaints in the first child. Her in the second pregnancy of the mother, she had a spontaneous abortion at the 3rd month of gestation. She's unsure of the cause, but the doctors had informed her that there was excess fluid inside the lungs of the baby. And this was in the 3rd month of gestation, sir.
So early trimester.
Yes, sir. Yes, sir. And 2 years later, she had a spontaneous conception, and which she delivered via LSCS in view of breech delivery, which is the current baby, sir, who's 5 months old. And there's no history of any unexplained death in the family, and there's no history of seizure disorder, developmental delay, or any similar complaints in any of the other family members. Her diet history. Currently, the baby is on infant formula powder with water. She takes about 60 ml 10 to 12 times a day via Vati spoon feed. And she has a calorie deficit of 189 kilocalories and a protein deficit of 6 grams. And her course in the hospital, that is following her admission in our hospital, she was initially admitted in the ward. She was continued on pre-existing oral medications, along with the addition of an oral syrup, and an IV medication was added, which was considered to be antibiotics by the mother. However, 24 hours after she was admitted, her frequency of seizures increased, along with the presence of altered sensorium and low respiratory effort, for which she was shifted to the PICU. In the PICU, she was taken on oxygen support. Her oral medications were converted to IV formulations, and the mother was informed that her anti-epileptic doses had to be stepped up. The mother was also informed that the baby had a recording of high blood pressure readings and hence was started on oral medications for the same. Gradually, over 3 days, the sensorium of the baby improved. Her seizure episodes decreased to about 4 to 5 per day, and when she was breathing comfortably on room air, she was then shifted to the ward after 3 days.
So you mean to say that previous slide. So the child still had everyday seizures, 3 to 4 episodes, correct?
Yes, sir. The child
The
still has
frequency,
seizures.
the frequency has came down. However, the seizures
sir.
were not stopped completely, correct?
Yes, sir.
And how many antiepileptics child is on?
So currently, the child is on 3 anti-epileptics, but based on the mother's history that she provided, she isn't sure which are the anti-epileptic medications and which are the nutritive medications, sir. She was on 5 medications, sir. She was on 3 tablets and 2 syrups, sir.
Okay, so less than 6 months, the child is on having recurrent episodes of seizures. Would you like to consider something else also in this child?
Less than 6 months with recurrent seizures, probably either a metabolic disorder or epilepsy syndrome.
Genetic syndromes,
Genetic
any
syndrome.
as far as seizures or epilepsy is concerned, less than 6 months, any vitamin dependent seizures?
Pyridoxine dependent seizures. Yeah, pyridoxine phosphate dependent seizures.
So any baby who is less than 6 months with refractory seizures, think about vitamin deficiencies like pyridoxine deficiencies. What else?
Yes, sir.
Any other vitamin deficiencies?
Folinic acid, sir.
What else?
Anything required for hair growth?
Biotin responsive seizures.
So,
In
what you have to
pyridoxine,
understand,
you have dependent seizure and deficiency, right?
Pardon, sir?
Dr. Vishnuji? In pyridoxine, you have either a deficiency or a dependency. There are 2 types.
Yes, sir. Yes, sir.
okay.
Pyridoxine dependent seizures, sir.
Okay, so yeah, go ahead now.
Based on the history, I would like to summarize my history. My patient was a 5-month-old female child, 3rd order by birth, to a non-consanguineous marriage, who had significant antenatal history of maternal hypothyroidism and left kidney enlargement on antenatal USG, which was followed by a normal birth history without the need for resuscitation, presented with seizures on day 3 of life, which progressed to multiple episodes with global developmental delay, with hearing and vision impairment, with failure to thrive, and abnormal rapid eye movements, to consider the possibility of nystagmus.
So what do you think it is?
So, based on my summary, based on the history, I would like to consider mainly the possibility of either an inborn error of metabolism or a neuroregressive disorder, or it could be a congenital malformation, a congenital infection, sir, such as either CMV or rubella, sir. There are points which go in favor of metabolic disorders, includes mainly the onset, sir. Day 3 of life, the seizures started from day 3 of life. They were progressive in nature. They were difficult to control, sir. It led to, and the occurrence of progressive encephalopathy, developmental delay, sir. There was a global developmental delay, along with her weight loss, difficulty in feeding, which all led to signs of failure to thrive. So,
yeah, basically you're dealing with a child who has got neonatal epilepsy. That's it.
Yes, sir.
Is it
Yes,
not?
sir.
So
Yes, sir.
you are dealing with a child who has got neonatal epilepsy.
Yes, sir.
So you have to think along those lines. what you have to realize is most of these neonatal epilepsies are genetic.
Yes, sir. Yes, sir.
Genetic syndromes are genetic. Even if you say IEM is also genetic. They're all genetic. They're all grouped under genetic. So you are dealing with a child who has neonatal epilepsy, progressive neurological disease. So amongst all these things, which one do you think is more likely? See, why we are discussing these things so much is because we are sure. I mean, there are not too many important examination findings that you'll be able to tell us. Not too many important examination findings would be able to tell us. So most of the things we need to analyze on history.
Yes, sir.
So can we figure out at
Mo-
this stage, knowing very well that the child had hearing as well as visual problems? Can we narrow down in any kind of diagnosis as far as genetic or EM, neuroregression?
because of hearing and vision problems,
Which one
I
among
would.
those groups is more likely, knowing very well that there was hearing deficit and visual deficit, both associated with possible nystagmus?
Congenital infections, ma'am. I would like to rule out either the possibility of CMV or rubella because of the involvement of both hearing and vision.
See, again, here it's very important for you to analyze what hearing and vision defects are, whether they are peripheral problems or central problems or problems with the connection. So until the time you know whether the vision or hearing problems are peripheral, connection or central, you can't really jump upon the fact that you're dealing with what exactly the problem is. You know that, right? I mean, you have problems both related to vision and hearing, peripheral problems, central problems,
Or it could be
connection problems.
Yes, sir.
So, based on history, can you really think in this child where the problem is?
No,
Central
sir,
or
but
or a connection?
based on the history, other than the fact that we can get an idea that the child is encephalopathic, sir, but where exactly the problem lies, no, sir. That is why I would like to consider all the 4 possibilities, sir, and then confirm my findings on examination.
Or whether it is cellular level, say basic will go to the cellular level. Can you think about something multi-system involvement, CNS involvement, failure to thrive, vision impairment, everything is impaired. So would you like to consider something at cellular level?
Cellular level, like
Any
So again, that is
inborn
organelle or anything in your cell that controls all the organs, or if that what
mitochondrial.
do you say is impaired, then
Mitochondrial
system, mitochondrial, right?
absolutely.
Yes, sir.
So eyes are involved, brain is involved. Yeah.
So if we were to analyze the history, the child has a progressive global neurological problem, and if we stick on to that, the deficits in both hearing and vision probably is of central origin.
Yes, sir.
With nystagmus.
The seizures because of seizures. Yes, sir.
No, seizures is obviously because of encephalon that is involved, right? Seizures is a manifestation of involvement of encephalon. Understood? So seizures are a manifestation of involvement of encephalon, and the encephalon is involved, and the involvement has been progressive, and because the encephalon is involved, and we know that encephalon also controls most of these things, vision, hearing, probably as a part of progressive involvement, there is so-called deficit in the form of vision and hearing also. And probably it is only encephalon. It doesn't, probably it is not there anywhere in the brainstem. Because you said,
yes, sir. No, yes, sir.
Yeah, you said, I mean, none of the chief complaints really fit into child having problems associated with the brainstem.
Yes, sir.
Okay, so very likely it is in the encephalon. It's a progressive neurological disorder affecting the encephalon.
Yes, sir.
So amongst all these four that you have said,
Yes, sir.
intrauterine infections, would it cause a progressive
Pardon, sir?
would congenital infections cause
Yes, sir.
progressive neurological problem associated with encephalon?
No, sir. It's unlikely that they will cause progressive encephalopathy, sir. That is why that comes third in my differential diagnosis. But the involvement of seizures with developmental delay and failure to thrive, involvement of both vision and hearing, these signs are suggestive of congenital infections.
Excellent. So now with this, what do you anticipate your examination findings to be? Just before getting into the examination, what would be your anticipation of examination findings?
Based on the history that is being given by the mother, since the child is
Obviously, there will be failure to
encephalopathic,
thrive.
yes,
Obviously,
sir.
the anthropometric indices would be affected because of failing to thrive. What other
Yes,
important things would you anticipate in this child?
So I would anticipate the child to be encephalopathic, sir,
No,
on
examination findings.
examination,
Yeah.
with decreased activity. Since the mother said the developmental milestones, I would expect the child to not have any eye contact and no response to stimulus. I would expect for nystagmus to be present on examination based on the history given by the mother. And the mother also gives a history of the child, she was not able to hold the child or carry the child properly. Probably the child could be hypotonic, sir, which is why there was a frequency of the child slipping when the mother tried to carry the child, and the fact that the child would not feed properly, sir.
Okay.
And
So basically, you would have signs from the encephalon going wrong.
yes, sir.
Okay. So would you expect a small head in this child?
I would expect a small head, sir, because of involvement of mostly the brain. If there is a central involvement and structural involvement, I wouldn't expect the baby to have microcephaly.
So you would expect this child to have a small brain. Okay. We'll
Yes,
see.
sir.
Yeah.
Yes, sir.
Yeah, start your examination. Then you can just
Any
tell us.
dysmorphism? Any dysmorph? Okay. Okay. Go ahead.
My general examination, the baby was lying in supine position on the bed. Her hips were externally rotated and knees partially flexed, with the arms slightly abducted and the elbows flexed. There was an intravenous catheter in situ over the dorsum of the right foot. The baby was conscious but drowsy. There was no activity, no eye contact or face regard. The baby does not recognize the mother. There was no social smile or vocalization.
I mean, what can you make out of the posture of the baby here?
The posture, the baby, usually neonates, they will be in a state of
No, this is
universal
not a
flex.
neonate, right? This child is no longer
Yes,
a
sir, an
neonate.
infant.
Yeah.
It's an infant.
So it looks like a pitted frog. No?
Very quick frog posture, sir. Yes, sir.
You could mention that. Pitted frog.
Yes, sir.
Quite hypotonic. Yeah.
Hypotonic, sir. Yes, sir.
I mean, I can also appreciate something happening with the thumb there. What is the great toe, left great toe? It's left there, or is it an
Pardon, sir?
abnormality? The left great toe,
Yes, sir. Yes, sir.
is it an anomalous great toe? What is that?
The left great toe, sir.
It appears abnormally flexed or
The left great toe, no, sir. There was more of overlapping of digits was present, sir. There was overlapping of the digits noticed, sir, mainly in the palms and the sole. In the palms and the
right. Yeah, go ahead.
and yes, sir. And vitals. The baby had a temperature of 98.7 degrees Celsius with a heart rate of 130 beats per minute. Both central and peripheral pulses were well felt, regular in rhythm, with normal force and volume, with a capillary refill time of less than 3 seconds. Her respiratory rate was 44 cycles per minute. Blood pressure was 95 by 65 millimeters of mercury, systolic between the 50th to 90th and diastolic between the 90th to 95th centile. I would also like to note that the baby was on antihypertensive medications when the blood pressure was recorded. She was on amlodipine, which was started in the PICU. Her saturation on room air was 97%. Pallor was present. There was no icterus, cyanosis, lymphadenopathy, or edema. Her anthropometry, she weighed 4.7 kgs, which came below the third centile according to the WHO growth charts and less than -3 standard deviations. Her length was 64 centimeters, which is between the third to fifth centile and between the median and -1 standard deviation according to the WHO growth charts. Her head circumference was 38.5 centimeters, which was at the third centile and which was between -2 to -3 standard deviation. And this did not come under microcephaly according to the WHO definition. Her chest circumference was 33 centimeters. Based on her anthropometry, the impression would be that the baby has failure to thrive. On
what has happened to the head size?
so the head size it's between -2 to -3 standard deviation, which is normal, sir, according to the WHO definition. If it is less than -3 standard deviation, then she would come under microcephaly, sir.
Yeah, I mean, what do you understand by that? That is the reason why I asked you just before you examining what do you expect the size of the head here.
Based
So
on the
if
history,
it's not really small, it just indicates that the
head is
size,
not small.
yeah, not really small. So what do you understand by this?
That it probably rules out the possibility, but there is some structural brain abnormality.
Not really. I mean, structural brain abnormality, there are so many structural brain abnormalities, like lysencephaly, boroncephaly, and all, they will not really present with small head.
Yes, sir.
You can have
Also, the possibility
megalencephaly
of
and
congenital infection.
I mean, you could just say that probably the brain was not involved.
The head does not
was
go
born.
with you.
Pardon, sir?
Was thinking.
Yes, sir.
Dr. Vikram, you can go ahead. Yeah.
No,
You were saying
too much. You could go ahead, sir.
No. That's. I think what Dr. Vikram was saying that the head size does not necessarily correlate with the seizures that the child has, and if the head is
Yes,
normal
sir.
in size, then it does not mean that there is no
There's no,
cytoarchitectural brain malformation. It can coexist. So there is no correlation to the head size per se, right? And
yes, sir.
if the brain was involved very early on, intrauterine, say in the second trimester or first trimester, because of a congenital infection, then you would expect the brain to be a small size brain. Okay,
Small
that doesn't seem to be the case.
Yes, sir.
And if it was a really catastrophic kind of thing that could have happened perinatally, that would have also led to a small brain, which is not happening here, which is not happening. So if you had previous growth parameters, brain growth parameters, it would be much more easier. The velocity at which the brain moves or the brain was growing, that could have also given me quite a lot of information here.
Yes,
Anyways,
sir.
cross-sectionally, you can say that the brain is not small. If you had longitudinal data, it would have been much more easier to say that it's not a really catastrophic, progressive neurological disease that's happening. So the problem there might not be related to severe alteration in the blood in the form of acidosis and all. Because if it was a severe disease and a lot of acidosis was happening, then the brain growth would have
Yes.
really got happened.
Yes, sir.
So, yeah, you can go ahead. Yeah.
On head-to-toe examination, head circumference was 38.5 centimeters. She had plagiocephaly. There was flattening of the back of the head, mostly due to continuous pressure over that region. There was
Positional plagiocephaly. Yeah.
positional plagiocephaly. She had bilateral frontal prominence. Her anterior fontanelle was open and measured 2 into 2 centimeters. It was not sunken or tense. Eyes, she had upslanting, bilateral eyes were upslanting with hypertelorism. On examination. Horizontal jerky nystagmoid movements were noted. She had a depressed nasal bridge. Her philtrum was prominent. Her mouth was open with a V-shaped upper lip, and she had a high arched palate. Bilaterally, ears were low set and prominent. On examination of the chest showed the presence of inverted nipples, and there were multiple Mongolian spots present over the lower back and gluteal region. On examination of the limbs, both in the feet and hands, there was hypoplasia of the nails. There was overlapping of the fifth digit over the fourth of the palm, and the presence of a deep palmar crease. Similarly, there was hypoplasia of the nails of the feet with a deep vertical plantar crease. There was no neurocutaneous markers seen.
You said many Mongolian
These are the
spots.
yes, sir.
Multiple Mongolian spots, right?
Yes, sir.
Does it constitute a neurocutaneous marker?
No, sir.
Multiple Mongolian spots.
Multiple Mongolian spots, they don't constitute a neurocutaneous marker, sir.
But suppose they are extensive, are there any neurological diseases where you will see a lot of Mongolian spots?
There are many.
Mongolian spots.
You will find exaggerated startle, excessive Mongolian force.
Non-ketotic hyperglycemia. Tay-Sachs
Storage disorder, gangliosidosis. You
Storage.
like to know gangliosidosis? Yes.
You need to keep your antennae open if you have multiple large Mongolian spots, because they are an indicator of neurocutaneous. I mean, they are a neurocutaneous marker.
There is inverted nipple. What is the significance of inverted nipple with abnormal, say, body fat distribution? What differential will come to your mind when the child is having, say, inverted nipple and excessive abnormal fat deposit on the body?
With abnormal fat deposition on the body and congenital glycosylation defects.
So just like cellular, we are dealing at the cellular level. What we are thinking about, multiple systems are involved, whether it is mitochondrial, whether it is congenital disorders of glycosylation. So these are the basic small clues which you are likely to get on your examination. You can go ahead.
This is a picture showing her hypoplastic nails. Moving on to CNS examination. The baby is conscious, drowsy, not active, does not recognize the mother's voice. There is no eye contact, social smile, or vocalization. Cranial nerve, examination of the olfactory nerve could not be elicited. Examination of the optic nerve showed there was no fixation to light. The baby does not follow objects. Direct and consensual pupillary reflex were present. Fundus examination was normal. Field of vision and color vision, however, could not be assessed. Third, fourth, and sixth cranial nerve showed that there was no ptosis or squint. Bilateral horizontal jerky nystagmoid movements were present. Bilateral pupils were 3 millimeters and equally reactive to light. There was no fixation or following of objects. Both direct and consensual pupillary reflex were present. Examination of the trigeminal nerve, corneal and conjunctival reflex were present and sensations over the face were intact. However, the baby was not sucking well. facial nerve, there was no facial asymmetry on crying, and the baby was able to close both eyes spontaneously. There was no deviation of angle of mouth. Bilateral nasolabial folds were prominent, and tears were present on crying. This is a video of nystagmus.
Okay, they are horizontal steps. Okay.
Vestibulocochlear. Yes.
Can you
Vestibulocochlear nerve,
describe the
there was no startle to
nystagmus?
sound.
Can you
So
describe?
she had, her nystagmus was jerky in nature, sir. There was a fast component and a slow component, and it was a horizontal nystagmus, sir. Horizontal nystagmus more towards the left side, sir, with the fast component towards the left side, sir.
Okay, so that was a bilateral horizontal.
Jerky nystagmus.
It is jerky. So I mean, we expected that only. And what about the lower cranial nerves? They're not involved, right? Okay.
Lower cranial nerve. Her vestibulocochlear nerve, there was no startle to sound. She did not turn her head towards the direction of sound, and bilateral horizontal jerky nystagmoid movements were present. 9th and 10th cranial nerves, the position of her uvula was central. Gag reflex was present. There was no pooling of secretions or saliva in the oral cavity. Spinal accessory nerve, the baby was able to turn her head towards both the sides. Hypoglossal nerve, bulk of the tongue was normal, and there was no deviation of the tongue when the baby was
The
feeding
brainstem
on
is
Vati.
normal. We already discussed that brainstem is going to be normal. It's the exceptional that's at fault here. Yeah.
Yes, sir. And examination of the motor system. On inspection of the bulk, there was generalized wasting of the muscles noted, which was flabby on palpation, and measurement of the circumference. Circumference of the mid arm on the right was 11 centimeters, and on the left was also 11 centimeters. Of the mid forearm was 10 centimeters, both on the right and the left.
Okay, the child had wasting, probably nutritional, right?
Yes, sir. Most probably nutritional, sir. Yes, sir. And there was no asymmetry noticed in the bulk of the muscle, sir. And mid thigh was 17 centimeters bilaterally, and mid leg was 11 centimeters on the right and 12 centimeters on the left. Moving on to examination of the tone, the posture, the baby was lying in supine position with hips externally rotated and her knees partially flexed, arms at the side of the child as previously described. She had a quick frog-like posture. On palpation, her muscles were soft and flabby. There was an increase in the range of movements and a decrease in the resistance noticed to passive movements, both in the bilateral upper and lower limbs. Active muscle tone was assessed using the 180-degree flip test. And on pull to sit, it was noticed that she had a complete head lag and her back remained rounded. And on vertical suspension, she was slipping, so she would slip through the examiner's hand, and there was no flexion noticed at the knee joint. And on ventral suspension, she would bring her chin to the midline and momentarily lift her head, but below the plane of the back. On prone position, her pelvis remained flat, and she would she would bring the head to the midline and lift the chin above the ground momentarily.
Okay, so what is your interpretation here?
There is severe hypotonia, sir, involving both.
Then you have to say that there is both truncal and
proximal. Yes, sir, truncal as well as distal hypotonia, sir.
Yeah, so there is generalized hypotonia.
Yes, sir.
Yeah, involving even the midline trunk.
Yes, sir.
So what do you make out of it?
She has severe hypotonia involving all the trunk, the proximal and the distal muscles, sir. I would like to consider the possibility that it could be either a central hypotonia or
It has to be. See, the child has failure to thrive. There is lots of muscle mass also
Encephalo-
failure to thrive nutritional. Along with that, the child also has probably encephalopathy going on. So it's a part of central
Yes, sir.
hypotonia. Yeah, global.
Yes, sir.
Central hypotonia.
Yes, sir.
Yeah. Go ahead.
Yes, sir. Her amyl-Thiessen angle, it was observed that there was an increase in her adductor angle beyond the normal of 110 degrees, an increase in her popliteal angle, whereas the dorsiflexion remained normal between 60 to 70 degrees. And on examination of the scarf sign, the elbow would cross the midline. The power of the could not be accurate. The power of the baby could not be accurately assessed due to the generalized encephalopathic state. However, based on our examination, the best observed power which was noticed was 2/5 in the bilateral shoulder as well as hip joint, and a power of 3/5 was noticed in the bilateral elbow joint, wrist joint, the knee as well as the ankle joint. On examination of the reflexes, superficial reflexes were normal, corneal and conjunctival reflex were intact bilaterally. The abdominal reflex was intact bilaterally. Anal reflex was present. Her plantar reflex was extensor bilaterally.
Okay.
And
So
on
what is the
examination-
impression of all these things?
Based on the impression of on her reflexes, power and tone, she has hypotonia, but her deep tendon reflexes are very exaggerated. So she has hypotonia with hyperreflexia.
Yeah, it's central.
Central cause. So there's
Yeah. Yeah. It's central hypotonia.
yes, sir, central hypotonia.
Okay. So what do you expect? Which part of the cortex to be involved?
Pardon, sir? Which part of?
Which part of the brain involved?
So mostly, I would suspect the involvement of the gray matter, sir.
Yeah.
Because yes, sir, because she has encephalopathy with central hypotonia, sir.
Absolutely. Yeah. Correct.
And examination of the sensory system, she was able to perceive pain and she was able to perceive crude touch. However, vibration and position sense as well as the cortical sensations could not be elicited in her. Cerebellar signs, when awake, she had bilateral, horizontal, jerky nystagmoid movements. There were no meningeal signs. Examination of the spine and peripheral nerves were normal. Examination of her primitive reflex, or all her primitive reflexes, including Moro's, rooting, sucking, placing, and walking reflex was absent.
Yeah.
And there was no persistence, but of primitive reflexes. However, her postural reflexes had not been appeared. Symmetric tonic neck reflex, the tonic labyrinthine reflex, writing as well as Landau's reflex were absent and had not appeared yet. Examination of other systems. On examination of the abdomen, showed a normal shape with the umbilicus central and inverted. All quadrants moved equally with respiration. There were no visible veins, scars, or pulsations. On palpation, there was a firm mass palpable in the left lumbar region, extending to the umbilical and the left iliac region, measuring approximately 6 centimeters from the left costal margin, with a smooth surface, rounded edges. It was non-tender to palpation, and the mass was ballotable, and the fingers could be insinuated between the mass as well as the
Probably
left
a renal
costal
mass.
margin, possibly a renal mass, sir, based on the examination. On examination of cardiovascular system, on inspection, there was no precordial bulge, pulsations, or engorged veins, and her apical impulse was palpable in the left fourth intercostal space, lateral to the midclavicular line. S1, S2 was heard, and there was splitting of the S2 heart sound. There was no murmurs. Respiratory system examination was normal, sir. There was no significant findings on respiratory system examination.
What do you make out of it?
Pardon, sir?
Good. So what do you make out of it?
Yes, sir.
Only the
Based
examination findings.
Now, based on my history and on my examination, I would like to summarize that she was that this was a 5-month-old female child, third order by birth to a non-consanguineous marriage, significant antenatal history in the form of maternal hypothyroidism and an anomaly in the left kidney on antenatal USG. She had neonatal onset convulsions on day 3 of life. They were progressive, difficult to control. She had feeding difficulties with failure to thrive, global developmental delay, controlled hypertension, and on examination, she had dysmorphic features. She was conscious, however, she was inactive. She had a floppy posture, poor proximal and distal muscle tone, with weakness of all 4 limbs, with hyporeflexia. And on examination of the abdomen, it revealed a renal mass in the left lumbar region, and cardiovascular system examination revealed splitting of S2. So based on the summary of my history and examination, functionally, I would like to give the diagnosis of a global developmental delay with progressive encephalopathy, with a syndromic central hypotonia, with seizures, impairment of vision and hearing, with a possible congenital heart disease and renal anomaly. Anatomically, I would like to diagnose it as primarily, predominantly involving the cortical gray matter with or without involvement of the white matter. The points which are in favor of suggesting the involvement of the gray matter is one is the global developmental delay, seizures, encephalopathy, and the presence of a central hypotonia. And the white matter may or may not be involved, such as in the early stages of evolving spasticity, there's usually hypotonia with hyperreflexia. So there could or could not be, may or may not be involvement of the white matter. Moving on to the etiological diagnosis that I would like to consider. The first diagnosis that I would like to consider based on my history and examination is a genetic disorder which involves multiple systems, such as either Zellweger's or Aicardi syndrome. The points which are in favor of the genetic disorder include history of previous fetal loss, anomaly scan showing enlargement of the left kidney, the presence of dysmorphic features in the baby, the fact that she had early onset seizures, along with global developmental delay, failure to thrive, central hypotonia, renomegaly, and congenital heart disease. Points which do not favor the presence of a genetic disorder. One is the fact that she had a normal head size. There's no history of consanguinity, and the fact that her encephalopathy is progressive in nature. The second diagnosis that I would like to consider in her is an inborn error of metabolism. And as discussed previously, fatty acid, mitochondrial encephalopathies or fatty acid oxidation defects, both of which can cause failure to thrive and can involve the heart as well. Points that are in favor of an IEM include an early onset seizures, which is difficult to treat, global developmental delay, progressive encephalopathy, failure to thrive, feeding problems, severe hypotonia, and cardiac involvement. However, the points which go against the possibility of an IEM is limb anomalies, which are usually not seen in metabolic disorders, involvement of the kidney, hypertension. There was no hepatomegaly in the baby. Also, she did not have any unusual body or urine odor and did not have any symptoms of vomiting. The third diagnosis that I would like to consider is a neuroregressive disorder of early onset, such as GM gangliosidosis or Pompe's disease. Points which go in favor of neuroregressive disorders are similarly early onset seizures, progressive encephalopathy, global developmental delay with regression of the language milestones, failure to thrive, and severe hypotonia, which suggests of muscle involvement, which is again seen in Pompe's disease. Points which go against the diagnosis of neuroregression are the fact that the baby had a normal head size, fundus examination was normal. Usually GM gangliosidosis and neuroregressive, they are associated with cherry red spots on fundus examination. Also, she didn't have any significant family history of similar complaints. There was no coarse facial features, which is usually seen in gangliosidosis, and there was no hepatosplenomegaly. And the last diagnosis that I would like to consider is congenital infections such as CMV or rubella. Points which go in favor of this include early onset seizures, progressive encephalopathy, global developmental delay, the fact that she had hearing as well as vision impairment, failure to thrive, as well as cardiac involvement, which is seen in rubella. And but however, the baby did not have any microcephaly. She had a normal birth weight, and she had rhinomegaly with limb defects, which all go against congenital infections. Also, there was no significant antenatal history suggesting infection of the mother. Also, on examination of the eyes, there was no cataract or chorioretinitis. There was no jaundice. There was no hepatosplenomegaly or any skin manifestations, which is usually seen in congenital infections.
Yeah, see, amongst all these things, and if you were to summarize just based on symptoms and signs,
Yes, sir.
how would you put it as? You have actually shown us an exhaustive list and you have done a fantastic exercise of trying to rule in and rule out. But if you were to just put in the problems in under, you have also given us APA, that is anatomical, pathological, probable etiological, and functional. But
Yes,
if you were
sir.
to just summarize and give us 3-4 points that we have understood about the process, disease process quite well, how would you put it down? Because diagnosis is difficult unless you do investigations. It's as simple as that. Unless you do a lot of investigations, it's difficult for us to come to or pinpoint the diagnosis here. Because ultimate
Yes, sir.
diagnosis you would get to know only by doing investigations.
Yes, sir.
Okay. This child would
based-
require a battery of tests and also probably an exome sequencing or quite a lot of other things. So
Yes,
if
sir.
you were to finally put across as 3-4 sentences, what would be your diagnosis? How would you
Based on 3-4 symptoms, I would like to consider progressive encephalopathy with severe central hypotonia, with the presence of dysmorphism, and the involvement of other systems, that is the renal and cardiac system. So based on these 5 features, usually it's genetic disorders because they with multi-system involvement because they involve multiple systems, and the fact that she has dysmorphism also. So mostly this dysmorphism with developmental delay, progressive encephalopathy, and central hypotonia with involvement of other systems goes in favor of a genetic disorder.
Absolutely. Genetic disorder. Yeah, it might not be a small genetic disorder. It could as well be a chromosomal disorder. We don't know because the child has significant dysmorphisms. It's morphologically the same child. And regarding the gray and white matter that you mentioned were really good. Right now, the child has more of gray matter signs.
Gray matter.
The child
Yes,
has,
sir.
but the only thing is that
More
the child is not having significant microcephaly that you see in predominantly gray matter disease. So right now, it's mostly poikiloencephalopathy. Okay, so
Yes,
it's a
sir.
progressive neurological poikiloencephalopathy with dysmorphic features, probably an underlying genetic mark chromosome anomaly. So you would.
Dr. Bhavna, what specific investigations would you like to do here? Tell me specific investigations.
Specific investigations. One is I would like to do a metabolic screening, sir.
Would that be first, or you want to do maybe a microarray or a karyotyping first? Your first diagnosis is genetic problem, right?
Yes, sir. Yes, sir. Yes.
So if you had limited money, would you put it in a microarray or would you send an exome sequencing? What would you do?
I would put it in exon sequencing, sir.
Okay. All right.
Okay.
Would you like to get, say, mitochondrial genome also? Now look, these genetic disorders, whether it is clinical exome, whole exome, or whole exome plus genetic mitochondrial genome. Now here would like to get mitochondrial also.
Sir?
Now in this child, would you like to get just whole exome sequencing or associated mitochondrial genome also?
No, I would definitely want to evaluate even for positive mitochondrial abnormalities. Sir.
And one more thing, you never forget about the electrophysiological test. EMG and NCV will give you a clue because the child is hypotonic. This is central hypotonia. Muscle is involved, brain is involved, eyes are involved.
Eyes are
So
involved.
your muscle eye brain is one of your differentials.
Muscle eye
Always
brain.
think about
Yes,
getting
sir.
your electrophysiological investigations.
Yes, sir.
What else would you do?
Apart from genetic testing, I would also like to get an MRI brain done to see
What are you expecting? Are you expecting?
involvement of
What exactly are you expecting?
involvement of mainly the white matter, sir, in the
White
MRI
matter
brain.
or gray matter?
Sorry, gray matter, sir. Gray matter, sir. Gray matter.
Right. Okay.
And with probably some involvement of encephalopathic changes also, sir.
Like?
Do you expect ex vacuo dilatation of ventricles?
Ex vacuo dilatation of the ventricles. There is a possibility, ma'am.
I mean,
So,
based on the dysmorphology and also the neurological involvement, have you made any attempt to look into possum? Or does it fit into any syndrome?
among the
Because the
genetic
child has
syndrome,
significant dysmorphological features. So have you looked into that and also the signs and neurological things that you have?
so genetically, ICARD syndrome is one which involves both the CNS and it causes renal and cardiac anomalies. So,
So the ICARD, I mean, this child has a definite neurometabolic disease. No? Has neurometabolic disease.
Yes, sir.
Because the way it is presented. So ICARD syndrome wouldn't really present like this as a neurometabolic syndrome. Predominantly, ICARD has a structural anomaly in the brain, right?
Have you checked for diabetes in this patient?
We've monitored her sugar.
Wolfram syndrome or something.
We've monitored her sugars, ma'am. There's no
They were normal.
abnormality. No, yes, ma'am. Her sugars were normal, ma'am.
Okay. So,
Can you tell us what the MRI shows in this child? If you have done the MRI.
Yes, sir. I have the. This was the MRI, sir, of the child, which it showed atrophy of the cerebrum along with delayed myelination and thinning of the corpus callosum with cerebellar hypoplasia. T2 hyperintensities were also noted in the central tegmental tracts in the brainstem. An MR spectroscopy was done. It was normal, sir. There was no glycemic peak. Only mildly elevated lactate was noticed on MR spectroscopy.
So nothing diagnostic really, isn't it? You don't have any
No.
diagnosis looking at the MRI. Okay.
No,
What
sir.
about the renal functions? How are the renal functions in this child?
So renal functions were normal, sir. Her urea was 35 and creat was 0.41, sir. Electrolytes also were normal, sir.
Right.
We
So it
also
is not
got
explaining the hypertension that the child has, isn't it?
no, sir. We
What
got
about
an
echo?
ultrasound done. 2D echo actually showed a small secondary atrial septal defect, sir, of 4 millimeter with the left to right shunt. Rest of the findings on 2D echo were normal, sir.
So how do you explain the hypertension in this child requiring antihypertensives?
It could be because her ultrasound showed that there was gross hydronephrosis of the left kidney with thinning of the cortex. So it could still, the hypertension can still be explained by the involvement of the kidneys, which is probably, it has not led to a kidney injury yet, sir.
It's a unilateral kidney disease.
Yes, ma'am.
So usually you will not get hypertension, no?
You won't get yes, sir.
So you require, a lot of glomeruli to be dysfunctional before your blood pressure really goes up. Yeah.
Yes, sir.
Right. Okay.
Dr.
Any other
Vishwa, do you
investigations?
think his ventricles are slightly dilated?
High ventricular dilatation is there, ma'am, but it is not that
Yes.
significant. And this
Not
MRI, even there is thinning of corpus callosum, there is hyperintensities in the bilateral tegmental tract which is seen, but however it is not having any specificity as far as any neurometabolic disorder is concerned. Now these kind of hyperintensities with diffusion restrictions, they can be seen in congenital disorder of glycosylation. Now this child is having recurrent seizures with inverted nipples, with these ill-formed nails and hypertegmental, tegmental tract hyperintensities. We can think about congenital disorder of glycosylation as first differential. Second being is the mitochondrial cytopathy.
Can I interrupt?
Any other investigations you have done, specific or anything you would like us to know?
Yes, sir. We got a metabolic screening done was normal, sir. Both ammonia lactate were normal, sir. And we got an EG done. EG showed burst suppression pattern, sir, which was suggestive of encephalopathy.
Right.
Can I interrupt, sir? Shijay.
Yeah, please.
Yes, sir. Actually, this case is of Dr. Vishwanath. We have worked up this case at DY together. So I have few slides about the case. If the question answer session done, I can share that screen set for the benefit of everyone, for the residents as well. Bhavna, can you please stop?
Yes, ma'am. Yes, ma'am.
So in this case, it was a 5-month-old female child with a global developmental delay, early infantile onset epileptic encephalopathy, failure to thrive, antenatally diagnosed renal malformation, previous first trimester fetal loss, everything indicating a genetic background with dysmorphism, with digit anomalies, inverted nipple, as Dr. Vishwanath said, all the MRI findings were non-specific, but when we correlate with all these findings, these are seen actually in congenital disorders of glycosylation. So here the metabolic screen was non-specific with mild elevation of lactate, succinate, fumarate, which can be seen in even mitochondrial with multi-system involvement. So we considered possibility of these two, congenital disorders of glycosylation and mitochondrial. So reviewed the literature back. So we had a similar case series. This is a case report of 2 siblings with similar facial dysmorphism and all these plantar crease, overlapping of digits, nail hypoplasia, and similar MRI finding. But here the cerebellar atrophy is more prominent. So we are clinically thinking of congenital disorders of glycosylation mode here. And out of these 4 types, the last one with the glycosyl phosphatidyl inositol anchor biosynthesis defect, the GPA anchor defects. So we have sent, so here again, there are multiple mutations, and out of them, so these are the clinical features they have mentioned in the literature. So we have done a mix and match. So it's fitting into PIGA or PIGV or PIGT. So very difficult, the genetic aspect. So finally, we have sent a whole exome sequencing and mitochondrial panel, and the report is awaited. So the clinical thoughts are the CDG in the GPI spectrum. Thank you.
Great. Please let us know what it turns out to be.
Yes, sir. Sure.
And I think we'll take leave here. We are already overshot the time limit that we have set. And I thank Dr. Bhavna for presenting such a wonderful case and very systematic approach. I'm sure Dr. Seizure has guided her very, very well. So Dr. Sampada, Dr. Seizure, thank you very much. And I thank our experts, Dr. Vikram and Dr. Kulkarni for being there. Thank you very much. And we'll see you again in 2 weeks. Thank you.
Yes, sir. Thank you, sir.
Thank you, sir. Bye-bye, sir. Good day, ma'am. Good day, Dr. Vikram, sir. See you.
Yeah.
Bye-bye, Dr.
Thanks a
Seizure.
lot.
Yeah.
Great
Thank you all.
presentation and congrats, Suji. Bye. Thanks a lot.
Yes, sir. Thank you.
Amazing. Fantastic.
Very busy.